Thank you so much for a wonderful session. Now I request our chairpersons to join us for a selfie after the oration. Thank you so much for their valuable time and input. Thank you so much, ma'am.
Thank you, Dr. Vandana. It's time to move to the next session, and that is on uh, two important lectures. Those are orations, and it is the customary of Cardiabcon uh, to have six different kind of oration, and it is on the name of different teachers and the different stalwarts of the diabetes, cardiology, and nephrology. And in this series, we have first oration and on the name of Professor Padma Shri Dr. K.K. Tripathi sir. And for this oration, I would like to invite two most important chairperson with us, Professor Dr. N.S. Verma sir and Dr. Vinay Tosh Misra. May I have? Yes. So kindly proceed to take your seats. So, and this oration is being delivered by none other than Dr. Anuj Maheshwari sir. So, by customary, I have to first introduce the person on the name of which this oration was started, and it is our proud privilege that we are having a living legend like Padma Shri Dr. K.K. Tripathi sir, and let's have a big round of applause for him, and it should be a standing ovation. I will request all of you to please stand up. Yes. So we are very grateful for you, sir, and we are highly honored to have a living legend who is available time by time to guide us. So, and may I have the opportunity to introduce Professor Dr. Anuj Maheshwari sir, who is a very important member of this Cardiabcon since the first conference which has been held in this Varanasi, and from time to time he is coming to us, he is guiding us in many aspects, as well as he is a very renowned person and he doesn't need any introduction. He is one of the person who has organized so many of conference from RSSDI to UPDACon to any prominent national body you name, he is member of. And most important thing is he is now running ACP, one of the very important organization who is recognizing physician and guiding physician in their day in and day out practice. He is also a living legend, and may I invite Dr. Professor Anuj Maheshwari sir to deliver his talk. Dr. Anuj Maheshwari sir.
Thank you, Dr. Ashutosh, and thank you, Cardiabcon team. Thank you, Professor Kamlaka Tripathi, for his graciousness. I am getting another oration in Varanasi. So Varanasi is oration place for me. In last 1 year, this is the third oration which I am speaking in Varanasi. So it's really pleasure for me. And not only pleasure, it's my gratitude to the people of Varanasi, my gratitude to the doctors of Varanasi and the institutions, those who are in the Varanasi, those who find me for worthy enough for these orations which they have given to me. So in next 25-30 minutes, I shall be talking about management of the hypertension in patients with diabetes mellitus. What is new? In last few years, on the platform of the Indian Society of Hypertension, we have jointly worked for the guidelines of the hypertension. And before that, RSSDI, which is the largest organization of the diabetologists and physicians, those who are practicing in diabetes across the world, in that organization also has released its guidelines for the management with hypertension in diabetes. Indian Society of Hypertension has released the guidelines overall management of the hypertension, which has also included the part of diabetes management, hypertension management in diabetes. So I shall be telling you the salient features of these two guidelines. Why did they come? What were really required to address with these guidelines? What are the problems which we were already having with the guidelines which were already available with us in the name of American College of the Cardiology, in the name of European Society of the Cardiology, and how were they lacking really for the Indian concern. So let me tell you about that. The content of this presentation shall be coming up in this way when I shall be talking about the hypertension in patients with diabetes, then we'll talk about the monitoring, then recommendations and summarizing. So we all know that hypertension is a major public health issue in India. It accounts for 10.8% of the total mortalities and 4.6% of the disability adjusted life years. Prevalence of the hypertension is higher in patients with diabetes. 50% cases of the hypertension also being diagnosed with type 2 diabetes, and prevalence of hypertension is nearly double in patients with diabetes than those who are not having diabetes. Risk is more marked in the elderly population, and coexistence of the diabetes and hypertension is more in India. So once we combine these diseases together and once we try to find out the relationship between hypertension and diabetes, in India this becomes more important because India we get a lot of population which is coming up from the youngsters. 70% population of the India is less than 40 years of the age as per the 2011 census. Still, the India is the capital of the hypertension across the world. Maximum number of the hypertension are in India. So definitely a big number is coming from those youngsters, those who are less than 40 years of the age. And why did they are getting the hypertension? Because we have been taught that hypertension is occurring because of the process of aging when the arterial walls gets stiffened. Then hypertension comes up. But why the stiffening of the arterial wall is occurring in those youngsters in their age 20s or 25 or 30s? And diabetes, this process becomes more and more faster. So once the diabetes and hypertension comes together, as the mother of both these diseases is the same, that is insulin resistance. The same soil they are coming up, and that's why their complications also remains the same. Their mechanism of going towards the complications also the same, and they always share the similar kind of the common pathophysiology. For example, the microvascular damage which occurs because of the type 2 diabetes that leads to the hypertension. Arterial stiffness already I have talked about. The youngsters of the India which are developing hypertension more commonly, sympathetic overdrive is playing a very important role in making them hypertensive. On the other hand, there are certain antihypertensive medications which are making the people diabetic, which are responsible for hyperglycemia, like diuretics, like beta blockers. Apart from that, nephroparenchymal hypertension is also associated with the diabetes. So if we talk about the insulin resistance, this is common between, or we can say common among the diabetes, obesity, hypertension, where we can see the increased level of the reactive oxygen species, where we get the high level of the oxy-free radical, high level of the RAS, and high level of the sympathetic nervous system. Altered renal sodium handling is occurring because of that and leading to the altered immune response and increasing the inflammation. So this makes a very complex cause-effect relationship between the hypertension and diabetes that involves obesity, visceral adiposity, and insulin resistance as the main pathogenic factors. So in this way, the hypertension is giving rise to the diabetes and diabetes is giving rise to the hypertension, and both of them when they are together, actually they are not 1 plus 1, 2, in fact they becomes 1 plus 1, 3. So as I already said, the common risk factors are causing both the diseases, may it be the genetic predilection, may it be the insulin resistance, may it be the dyslipidemia or the obesity. We get the same soil for both the diseases, and they leads to the complication through the atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, and arterial remodeling, and giving rise to the microvascular and macrovascular complications, ending up with the cardiovascular adverse outcomes. So that is the biggest concern. People die because of the cardiovascular adverse outcome. Those outcome may be the MI, those outcome may be the arrhythmia, those outcome may be some stroke which is causing the premature death. And nowadays we are also getting lot of concern regarding the sudden cardiac death also even in youngsters. So sudden death is again a thing for which we need to understand and we to think about why it is happening together. So management of hypertension in patient with diabetes lowers the risk of atherosclerotic cardiovascular disease. This is well established fact, but the risk of the cardiovascular complications is higher in patient with hypertension and diabetes together. But every 10 mm of lowering in systolic blood pressure in hypertensive diabetic patient can reduce 12% complications pertaining to diabetes. 50% reduction it can bring about a mortality due to diabetes related complication. 13% reduction you can see in the microvascular complication and 11% reduction you can see in MI. So good BP management works well if diabetes and hypertension are together. If your patient is diabetic, then you should be more concerned about their blood pressure, and every single mercury or drop in the systolic blood pressure takes your patients away from the complications. There has been a large gap among the international consensus as far as the diagnosis of the hypertension is concerned. For a long time we were knowing that hypertension can be diagnosed if the blood pressure is 140 systolic and 90 diastolic. But there has been a gap, and there has been also a disagreement among the world community and various organizations which are leading towards the diagnosis of hypertension guidelines, may it be American College of Cardiology and European Society of the Cardiology and European Society of Hypertension. European Society of Hypertension and European Society of the Cardiology still understand that 140/90 cutoff should be maintained, and that is a right thing for the diagnosis of hypertension. On the other hand, the American College of the Cardiology says that it should be bring down by 10 mm of mercury, may it be the systolic or diastolic both. Means 130 systolic and 80 diastolic should be the cutoff for the definition of hypertension as per the American College of the Cardiology. Now question arises, what should be in the Indian setting? We Indians are more prone to develop the metabolic complications. We Indians are having a lot of hypertension despite being in younger age group when the arterial stiffening has not occurred, or there may be the multiple reasons of the arterial stiffening with us which may lead to complications. So that's why the hypertension should remain a big concern for the Indian population. For that thing, keeping in mind Indian Society of Hypertension guidelines kept the optimal blood pressure less than 130 and less than 85 diastolic and less than 130 systolic. The recommendation for the cutoff for the diagnosis of hypertension is 140/90. It still exists with the Indian Society of Hypertension. But once the person is diagnosed of having the hypertension, we should try to maintain or try to target to achieve the blood pressure of less than 130 and less than 85. What are the methods of the blood pressure measurement? It has also been very much variable across the world. Earlier we were knowing that mercury sphygmomanometer was the gold standard for the blood pressure measurement. But now the ambulatory blood pressure monitoring is considered the gold standard for the blood pressure measurement. It has replaced the mercury sphygmomanometer as far as the gold standard is concerned. Nowadays, the clinic measurement of the blood pressure is not considered appropriate. Earlier, you must have heard about by our elders, and even you might have gone to some doctors and saying that I have measured my blood pressure and this blood pressure was this. So he must have told to you, no, I will measure your blood pressure and whatever I will find that would be the right. But the present concern is say this, that whatever is measured in the clinics, whatever is measured in the doctor's office, that is not the thing on which you can decide finally that patient needs the treatment, especially if it ranges in the high normal or in the grade 1 hypertension. If it is ranging in the grade 2 hypertension, obviously the chances are very less that it will be different when you will go to home. But if it is lying in the grade 1 or it is in the high normal, then chances are very high that it may drop down to the normal when the person remains in the relaxed position or in the homely condition. So that's why the home blood pressure monitoring has become more important than the clinic blood pressure monitoring, and obviously the ambulatory blood pressure monitoring is the gold standard which can really help us in determining white coat hypertension, mass hypertension and nocturnal hypertension. So what is the difference between these three? When we talk about the white coat hypertension, you must have been understood very well that if it is in the doctor's clinic, somebody is having the high blood pressure, but at home it is normal, this is the white coat hypertension. If somebody is having just reverse of that, means at home he is having the high blood pressure, but at the doctor's clinic it is normal, that it could be the mass hypertension. Nocturnal hypertension is that which is seen normally in many of us, and it should be in every human being, that in the night a blood pressure should drop little bit. But if this drop which happens to be in the night or which should be in the night is not occurring, that is called nocturnal hypertension. 10 mm to 20 mm mercury, the blood pressure should drop in the night time when a person is sleeping. If this drop is not occurring, even when the blood pressure is normal across the 24 hours, but drop is not there in the midnight, it is a alarming signal for the cardiovascular adverse outcome. So ambulatory blood pressure measurement is recommended for patients with diabetes and hypertension for reducing risk of post-treatment complication. Overall improvement of the blood pressure control. It is recommended to opt for standing position during blood pressure monitoring in elderly patient. And calibration and validation of the BP measurement instrument must be considered on the priority, because nowadays multiple varieties of the home blood pressure monitoring instruments are in the market. So calibration is very much important. ADA recommendations for the blood pressure measurement in the diabetes patient is that blood pressure must be monitored at every office visit in the patient with diabetes. In patient with elevated blood pressure, multiple readings must be taken for the diagnosis of hypertension, and that too at the different times of the day. Now come over to the dietary and lifestyle recommendations. Lot of tips has been given by my previous speakers, Rekha ji and Dr. Mary D. Cruz, about the lifestyle recommendation. Here what I can say in the light of the recommendations given by the Indian Society of Hypertension as well as RSSDI, if the office-based blood pressure is more than 140/90, this is a time to start the lifestyle modification without thinking any other thing, with pharmacotherapy. Now there could be a difference of opinion at 140/90, or if it is more than 140/90, where we should start with the single drug or we should start with the dual drug therapy as far as the pharmacotherapy is concerned. But before starting, this must be confirmed by the ambulatory blood pressure monitoring or the home blood pressure monitoring. Systolic blood pressure target value should be the 120 to 130. If it is crossing the 130, it should be associated with the lifestyle modification. Nutrition education about role of diet and knowledge of healthy food choices must be given to the patient, and physical activity should be the integral part of the lifestyle in the form of the brisk walking, at least for the 50-60 minutes, 3 to 4 times in a week is must. And key dietary recommendation must include the avoidance of the sodium and low sodium diet, which is very much recommended and by almost all the organizations and their guidelines. Let's talk about the pharmacotherapeutic recommendations in diabetic hypertension. Individual profile of the patient and their response to the treatment must be evaluated for the selection of the most suitable treatment agent for hypertensive management. It's all agreement about all the organizations that combination therapy should be recommended, but combination should never be of the RAS blockers. Combination should never be the ARB and ACE inhibitors, although any one of them can be chosen with any other class of the drug for the combination, and combination therapy ideal could be ARB combining with the calcium channel blocker, to be initiated for the hypertensive patient for better blood pressure control, reducing risk of complication and better patient adherence. Why I am saying that? Lot of ACE inhibitors patients may leave their therapy because of the coughing and some problems. For that, the adherence comes in jeopardized. ARBs, either alone or in combination with the calcium channel blocker, can be used for the blood pressure control in diabetic patient. And they must be preferred over the ACE inhibitors, patient with hypertension, telmisartan, azilsartan being selected as the first line agent. These are the guidelines given by the RSSDI. In patient at the risk of the CVD, renal disorders, cerebrovascular disorder, combination therapy must be preferred for the reduction of patient mortality. Calcium channel blockers must be preferred over the beta blockers and thiazide in combination therapies with ARBs. The use of the beta blocker and thiazide diuretic must be avoided in patients with diabetes and hypertension because of their potential to cause cardiovascular events and hyperglycemia together. Monitoring of the electrolyte level, serum potassium, creatinine levels, as well as regular evaluation of the kidney function is recommended for patients with diabetic hypertension based on the choice of the treatment agent and their risk profile. So let's talk about the guideline comparison of the goal blood pressure and initial drug therapy. Since from the very early of 2014 hypertension guidelines, we were knowing and we were accepting that the goal blood pressure should be 140/90 and the cutoff for the diagnosis should also be the 140/90. And it has already also been taught to us, and it has also been given this by all the guidelines, that initial management could be started with the ACE inhibitors or ARB. If we want to combine, that calcium channel blocker can be the first choice to combine with them. But in International Society of Hypertension 2020 has released its guidelines, which has made a little change, that they said that if the patient is having the chronic kidney disease, the target blood pressure should be less than 130/80. Although they allowed to keep the 140/80 target blood pressure in elderly, even in the CKD. They recommended to start the treatment with the RAS blockers as a first line, combining with the calcium channel blockers and diuretics if it is needed to be added. KDIGO, which is the Organization for the Kidney Diseases, and its recommendations for the same, CKD with proteinuria and CKD without proteinuria, they have given the different targets for the same. CKD without proteinuria, they are allowed to go to relax till the 140/90, but if it is with proteinuria, then KDIGO says that target blood pressure should be less than 130/80. ACE inhibitors and ARB should be the first choice, any one of them. As far as the renal replacement therapy is concerned, the patient, those who are getting the renal replacement therapy, they should also be asked to keep their blood pressure less than 130/80. For patients with hypertension and diabetes, blood pressure target must be kept close to 120 to 130 mm of mercury for reducing the risk of stroke. So ARB helps to reduce the risk of cardiovascular events, cerebrovascular events, renal complications. Most widely used antihypertensive medication because of their similar effects on cardiovascular outcomes. Safer, tolerant, more efficacious than ACE inhibitors for the blood pressure control, less side effects are there. Risk towards side effects is also lower with those agents compared with ACE inhibitors that induce cough. Therapy having a combination of an ARB and ACE inhibitor is not recommended as it is associated with an excess of adverse renal events. ACE inhibitors may be preferred as a first-line treatment agent in patients with diabetic hypertension as an alternative to ARB if it is not acceptable or cannot be given for some reason. Both these agents effectively reduce the risk of CVDs in high-risk patients, although ARBs are more efficacious. Both ARBs and ACE inhibitors effectively reduce the risk of end-stage renal disease. So once we think about the ARBs in hypertension patient with type 2 diabetes, they are administered in combination with other agents such as calcium channel blocker or thiazide diuretic. Now the question arises, treatment has been started with the ARBs or any RAS blocker, maybe ACE inhibitors, but what to add with the another medication? And another thing is that what ARB should be better in which condition? RSSDI has been very much clear in its recommendation, which other organization has not come up with so much free recommendations, that telmisartan and losartan are the most effective choice for the reduction of the cardiovascular risk factors. Telmisartan must be selected as the first line ARB agent in diabetic patient because of its beneficial impact on fasting blood glucose and insulin level. In those at a higher risk of the stroke, losartan must be preferred, whereas telmisartan is recommended in patient having a history of atrial fibrillation. Azilsartan improved the diastolic function of the left ventricle in patient with heart failure with preserved ejection fraction, also is a suitable agent for the hypertension control in CKD patient. Beta blockers in diabetic patient, there has been previous history of cardiovascular disease in the form of the MI, heart failure, coronary artery disease, stable angina. Definitely the initial management of the hypertension can be combined with the beta blocker. So beta blockers are per se not recommended independently and are not actually indicated as part of the combination therapy with ARBs or ACE inhibitor in presence of diabetes. Safety of the beta blockers in diabetic patient have been found to be challenging and have been found to be controversial, like promotion. It promotes the hypoglycemic state. It increases the risk of cardiovascular events in patients with diabetes, and it is not really recommended unless absolutely indicated. When we talk about the calcium channel blocker, it is widely used as first-line antihypertensive agent, exert potent antihypertensive action, more pronounced preventive effect on the stroke, significant reduction in the risk of coronary event, reduces cardiovascular morbidity and mortality. Can be used alongside of the ARB as a part of the combination therapy for management of the hypertension in diabetic patient. There are certain novel calcium channel blockers which has hit the market in the recently, like benidipine and cilnidipine, and this has also been thought by multiple studies that they can be preferred for their specific pleiotropic benefit above the antihypertensive action. So if we talk about the cilnidipine, RSSDI guidelines are very much clear about that cilnidipine and benidipine in diabetic hypertension can be preferred in certain situations of the hypertension over other traditional conventional calcium channel blockers as far as they are associated with the tachycardia, hyperuricemia. They also give the better tolerability as compared to the previously existing calcium channel blocker. Can be preferred in patient with proteinuria or pedal edema. They also improves the insulin sensitivity. Cilnidipine may be the preferred CCB in combination with the ARB for the management of the diabetic hypertension because it not only reduces the risk of complication, better patient adherence, but also lowers the pedal edema in patient those who are in the end-stage renal disease or in the kidney complications together. And it has also been found to be useful in patient those who are with the tachycardia. Diuretics in diabetic hypertension. Selective diuretics are not commonly used for the management of hypertension in diabetics. They are indicated in certain cases like elderly patient with existing cardiovascular disease. Use of the diuretics like hydrochlorothiazide is not recommended because of its hyperglycemia potential. Low dose spironolactone is recommended in patient with those who are having potassium level less than 4.5, eGFR more than 45. Thiazide-like diuretics like chlorthalidone demonstrated superior blood pressure reduction in patients with resistant hypertension as suggested by the RSSDI guideline. Combination therapy, if we talk about the combination therapy, there are certain potential combinations which are found to be more efficacious in certain different conditions. For example, if we talk about the ACE inhibitor combining with the diuretic, they are found to be reducing the 28% risk of the stroke reduction in patient with stroke or TIA. In patients with diabetes, the same combination have been found to be reducing 9% reduction in micro and macrovascular complication. Patients, those who are having the hypertensive more than 80 years of the age, we could see that 34% drop in the cardiovascular events with this combination. Once the ARB is combined with the diuretic, we could see that hypertensive, those who are having 70 years or more than that, 28% lesser risk of the non-fatal stroke, 27% lesser risk of the cardiovascular events we could see when calcium channel blocker combined with the diuretic. ACE inhibitors combined with the calcium channel blocker in the older patient, especially those who are having the isolated systolic hypertension, we could see 37% drop in the cardiovascular event. Beta blockers, those who were combined with the diuretic, not only with the older patient, elderly patient with the isolated systolic hypertension, we could see 36% drop in the stroke. We could also see the 40% drop in the cardiovascular event, and 14% reduction in blood pressure could be seen while combining the ARB with the calcium channel blocker with lower incidence of the cardiovascular events. So let's talk about the indications of individual drug classes based on the guidelines and clinical studies. So if we talk about the heart failure, almost all drugs could be recommended except the calcium channel blocker. They are recommended at the last, as per the various clinical trials done by the ACC, AHA, Merit HF, number of clinical trials I have mentioned after that. Patient, those who are coming after the MI, they should be preferred either beta blocker, ACE inhibitor, ARB, calcium channel blockers, and aldosterone antagonist. And it has been seen that patient, those who are coming with the heart failure or impaired LV function in patient with contraindication to the beta blocker, you can use certain calcium channel blockers, especially the non-dihydropyridine calcium channel blockers can be used. If ACE inhibitor is not tolerated, obviously you can go for the ARB in post-MI infarction. High coronary disease risk, ARBs are not very much preferred agent, and aldosterone antagonists are also not very much preferred. As far as the diabetes is concerned, we can see that diuretics and beta blockers are less preferred. Chronic kidney disease could be seen with the ACE inhibitors, ARB, and calcium channel blockers as a preferred agent, and recurrent stroke prevention could be seen with the ACE inhibitors, calcium channel blockers, and diuretics. So these have been the drugs which could be preferred in various situations. So yes, just I am coming to the last slide. This is the 2 minutes showing here. So management of the hypertension in patient with diabetes, we have the 4 basic groups of the drugs for the patient, those who are having the diabetes. ARBs, ACE inhibitors, calcium channel blockers, diuretics. The most preferred ARBs for the diabetic patients is the telmisartan, followed by the azilsartan. As far as the ACE inhibitors are concerned, it can be used when patients are not responsive to the combination therapy with ARBs and you want to change the ARB component. Calcium channel blockers, which are preferred for the management of the hypertension with diabetes, are the cilnidipine and amlodipine, and diuretics can be used in cases of the resistant hypertension and elderly patients in addition to these agents when they are required as a combination therapy. The first line agents in combination therapy, which like as a cilnidipine, can be used in patients with existing CVDs, CKDs, or other complications, especially those who are with the pedal edema and tachycardia. Thank you very much for your kind listening.
Thank you, Professor Maheshwari, for in these 30 minutes you have given everything about the hypertension management and clarifying so many things. As a customary in oration, we do not welcome the questions. If still you have any question, you can discuss to Maheshwari after this.
I think as far as the hypertension management is concerned, a lot of things are there where consensus is not there, where many people are not agreeing on one part. Diagnosis cutoff is one of the most important things where people are not agreeing on one cutoff and one level of the blood pressure, systolic and diastolic. So a lot of things are there where multiple thoughts are running, but we need to come at one consensus, and I tried to make you here the taking at least the 2 main important guidelines which are more important in perspective of the Indian, like Indian Society of Hypertension and RSSDI, in perspective of the patient, those who are having the diabetes. So hopefully you might have been found your material which may be required over your clinics.
Just one
Yes.
clarification if you could give us. What is the best time to take blood pressure in the home setting?
Yes, good. In the home blood pressure monitoring, best time to take the blood pressure is in the morning when you are getting up from your bed. Better after getting relieved from your pressures, may it be the bowel pressure or may it be with the bladder pressure, and coming back, wait for 5 minutes without eating anything, without drinking anything, check the 2 readings, and what we usually suggested that take the 3 reading, discard the first reading and take the average of the remaining last 2 reading. The same thing should be done when you are going to sleep at the bedtime. So these are the 2 times when you should measure your blood pressure, at the time when you are getting up and time when you are going to sleep.